Good afternoon, everybody, and thank you for inviting me to spend 45 minutes or so with you this afternoon. And what I'm thinking I'll do is I'm going to give you just a quick overview of how we are looking at social health as an organization at Kaiser Permanente, give you some specific examples of how we're addressing some of the key health-related social needs for our own members and some of the work that we're doing in the communities to help lift up the conditions for health and equity in the communities where Kaiser Permanente operates. So I have about 20 or so slides. We don't have to cover all of them, but we'll cover as much as we want. And I'm hoping that we'll leave some time towards the end for Q&A. Is Q&A okay? Should I plan for Q&A towards the end? Yes, I'm seeing lots of nods here. All right. So thank you again for inviting me. I think many of you might be familiar with Kaiser Permanente. We are the largest integrated nonprofit health system in the country. We started 75 years ago as an integrated care delivery program. We're both care and coverage. So we have about 12.3 million members across our footprint who depend on us every day for care and for coverage. So we provide the health plan services and we provide care delivery across our footprint. 12.3 million members. We're in communities where about 68 million people live. We're right here in Atlanta, but we're also in big presence in California, along the West Coast, and in Oregon, Washington, Hawaii, but also in the Mid-Atlantic states, Maryland, Washington, Virginia, in Colorado. So we have a pretty big presence. And since we were born as an organization, we've been about improving the health and well-being of our members and improving the health and well-beings of communities. And we truly believe that those go hand in hand, because there is no way you're going to lift up the health and well-being of your communities if we don't start by doing a really good job in improving the health of our 12.3 million members. And at the same time, our members, our 12.3 million members, are not going to be able to optimize their health if we're not focusing on improving the conditions for health and equity in the communities where those members live. And that's why we truly believe that those two parts of our mission, the members and the communities, go hand in hand. And I'm going to start by just reflecting how 75 years ago, Dr. Sidney Garfield and Henry J. Kaiser came together and said, what can we do to lift up the physical health of people in our communities? And as an organization, we've built a network of primary care doctors and specialists to support the physical health of our members. And then we started realizing that physical health alone is not enough. You really need to be also focusing on mental health. And so over the years, we've built a mental health network that included therapists, counselors, psychiatrists, peer support specialists to support the mental health of our members. And now what we're saying is paying attention to the physical health and mental health alone is not going to be enough. We really need to be paying attention to the social health of our members. And with the same rigor, we're building an integrated network that pays attention to the social needs of those members that we have. So our concept of health has been evolving to include physical health, mental health, and social health. And most importantly, for an organization like ours, being able to integrate all of that together. And that's really the spirit of our social health practice as an organization. A few months ago, we surveyed people living in this country, across the whole country, across different sociodemographics, different geographic areas. And we've asked people about their social needs, and we focused on the 5 health-related social needs: housing stability, food security, transportation, social isolation or social connectedness, and your ability to be able to pay your water and electric bills. We truly believe that those 5 social needs are really critical to health. And when we surveyed people living in this country across all socioeconomic, demographics, and geographic areas, what we found out is that 68% of people in this country have had at least one unmet social need in this past year. 68%. I mean, think about it. If there's probably, 300 people in this room, 68%, that's almost 200 people in this room, have had at least one unmet social need. And then what we also learned when we talked more to folks is that 1 in 4 people in this country, those unmet social needs were a direct barrier to health. So 25% of people, 1 in 4, have had to make a decision, a choice between do they pay their rent this month or do they pay their copay for their medications? Do they buy food to put food at their dinner table, or do they pay their deductible to be able to have their surgery that they need to do? So that 1 in 4 number becomes really relevant for us as a health system that's looking at millions and millions of members every day. And we've also learned that when you have an unmet social need, you're twice as likely to rate your health as poor compared to those who don't have social needs. And 97% of the people we surveyed said that they expect their medical providers to actually ask them about their social needs as part of their health visit. And all of those learnings become so relevant to us as we think about our care delivery. And not only 97% of those we surveyed expected their providers to ask them about their social health, about 80% of people living in this country, they expect their medical providers to actually connect them to services where they can get those social needs met. And that becomes even more relevant for us as an organization. So when we took a step back and said, okay, what are we doing for the across our footprint, how are we addressing the social needs of our members, we've realized that we have about 35 different ways that we did that. And we did it very region-specific, service area-specific, and we didn't have a systematic approach to addressing, screening, addressing, and responding to the social needs of our members. So a year and a half ago or so, we took a step back and said, what would it look like for us to develop the rigor of identifying members, connecting members, optimizing the health of members when it comes to the social needs, the same way we do physical health and we do mental health. So we've partnered with an organization called Unite Us, and now we're building networks across every one of our footprints. We're on a trajectory to build 39 networks across the country to be able to have these social providers, particularly addressing the 5 health-related social needs, totally connected through our electronic health record system so that our doctors, our nurses, our social workers, but also our own members on their kp.org app, that they can be able to self-refer and identify providers in their communities that are be willing to accept those members and address their social need. And we're already live in one of our regions. We have 3 regions that are going to be going live in the next 6 months, and we have a trajectory to have all of our service areas up and going with that network of social providers that's addressing the social health needs of our members the same way we have networks for physical health, networks for mental health, and they're all integrated in our electronic health record system, which becomes a true health record system that looks at all these different aspects of health. So we're really excited about this effort. We're starting to learn a lot from the first region that's going live with the bidirectional referrals that are happening in our communities. And during the Q&A, I'm happy to answer any more questions about that network. So I'm going to pick and choose 2 of these health-related social needs and do a little bit of a deeper dive on. I'm going to talk a little bit about food security and then a little bit more about housing as 2 key components of the social needs that our members are dealing with. And I think for food security, everybody in this room, this is no surprise, food security and health are so interconnected. We know that when you are food insecure, probably your total cost of care is about 45% higher compared to those who are food secure. We also know that people living below the 138% of the federal poverty level are much more likely, 50% more likely, to be food insecure. And then when we started looking at our own membership, we started realizing that in California alone, we have about 238,000 Kaiser Permanente members who are on Medicaid who qualify for food stamps but don't get it. 238,000. And if you think about it for a moment, multiply that by about 150 to 160 bucks per member per month. We're talking about $360 million that those members are leaving at the table, not tapping into a benefit that they would help them live healthier lives, live with more dignity, and be able to put food at their dinner table, let alone spending that money in the communities from an economic perspective is an important economic effort. We also know that there are particular instances where food insecurity is even more tied directly to healthcare costs, and this is, for example, with pregnant women. We know we have about 31,000 low-income pregnant women in California, and for those members who are food insecure, and if we don't address their food insecurity, chances are they're going to get preterm birth, they're going to get a low birth weight baby, and all the cost that comes associated with that. So the fact that we have 1 in 9 people in this country are dealing with food insecurity becomes a significant issue for us to address, and the fact that it's so connected to healthcare. So a year ago or so, we launched a Food for Life, which is our effort to address food insecurity in our communities, starting by focusing on our own members, but also looking more broadly about how do you advance a global agenda around food insecurity? What are the economics models that we need to push so that people have more money available to be able to spend on healthy food? How do you expand choices in our communities so you're not just buying food from the corner stores that's selling the chips and the sugary drinks and others? And then how do we lift up the food and nutrition literacy in our communities? All of those become so critical as you think about food insecurity. And one thing we've learned, we've done a lot of ethnographic studies in the communities where we serve, and we've learned more and more about how personal food is. People who are food insecure, it's not just you give them any type of food and that's all what they need. Think about food for all of us here. It's a personal experience. It reflects your heritage, your culture, the way you connect with your family, with your friends, with your neighbors. And so it's really important as we think about how we're addressing food insecurity to have a broader perspective than just making sure that you have the money to be able to buy the food or you have the food. We actually started our food insecurity work in Colorado, where we've literally screened every one of our KP Medicare members in Colorado, and we found about 6% of them have food insecurity. And then when we started going to pediatrics clinics, we've realized that in one clinic, 12% of members of kids are coming from families with food insecurity. In another clinic, it was 18%. So we started building systems and referral mechanism to help support those members getting the services that they need, and if you qualify for food stamps, to get you signed up for food stamps. So we've learned a lot from the work in Colorado, and now we're taking a step back and implementing this work system-wide with a big focus on California. So I'm going to just spend a moment on California. When you look at the number of people who qualify for SNAP in California and those who actually get it, there's a big gap there. And California actually ranked 47th when it comes to the states of making sure that if you qualify for food stamps, you're getting it, for a whole set of reasons, including a very interesting approach that every county in California administers its own way, the way they administer the SNAP program. So it creates a lot of confusion. In some counties, you need to go in person to do interviews, and others you can do it online, and other places you have to have a phone interviews, and it really adds a lot of barriers into this bureaucratic system. So earlier this year, well now last year, we are now in a process of engaging 850,000 members in California who we've done some predictive modeling to say that those members might qualify for food stamps and they're not getting it, or we think they qualify for food stamps, but because we couldn't get the data exchange with the state, we're not sure if they have the food stamps or not. So now we're engaging them through 3 different cohorts in a well-designed intervention that would hopefully allow, well-phased intervention that would hopefully allow us to test the impact of that work and trying to connect with members using different modalities. We are texting members, we're emailing members, we're mailing them letters, we're calling them, and for a small subset of those members, we're even having a lot more assistance in supporting those members getting enrolled in food stamps. We've launched this a few months back, and we've already seen 30,000 members who actually started the application process, and we have over 12,000 members who've completed the submittal process, and we're working with them. We're working with those who still haven't completed their application process to get them to complete the application, getting it submitted, and hopefully get them into the SNAP program. We have a strong evaluation component there. The fact that our system is integrated, we can take a look at the impact on health outcomes, total cost of care. So we're going to be able to validate some of the data and some of the evidence that's out in the literature that's connecting food insecurity with total cost of care. We're really excited about this effort. And then in April of this year, so 2 months from now or 3 months from now, we're launching 4 medically tailored meal efforts in 4 of our service areas. So 2 in Northern California, 1 in Colorado, and then 1 in Oregon, where we're identifying members who are in the hospital, getting ready to be discharged, and then we're also in a phased, methodical way designing this intervention, executing the intervention to get those members medically tailored meals, and then we will be able to track their total cost of care, their readmissions, all of that. We know from multiple studies that medically tailored meals would lead to about 50% reduction in readmission rates. So we will be trying to be carefully monitoring the impact of those interventions. We're really excited about that. So I'm going to take a moment and I'll see if my tech skills would work and share with you the story of Marvelyn, one of our members who benefited from the food stamp program. So let's see if I can get it right.
My full name is Marvelyn Janine Nunu Walker Evans. Typical day is serving other people, like my grandkids, going to help my daughter. Wherever the need is, if I can do it, it's what I do. I'm on a limited income, a little over $900 a month. I had a lot of struggles and barriers with affording food. I would beat myself up when I would watch people in the stores when they could just go buy what they wanted and not trip, because I couldn't do it. And I was dealing with food banks, but the food banks, they give you a lot of food, and I'm so picky that I didn't eat. It impacted my health, my well-being, and then I deal with my grandkids a lot, so then it impacted them. I was down to 95 pounds, and I was terrified that, I didn't want to keep living like that. So I made a goal that I would get off going to the food banks. But that didn't come about, even though I had the dream, until my Kaiser Permanente home care worker told me about CalFresh, food stamps. And it's just such a blessing. They give me $200 a month, and I can go to the store, I can live. I can go in my refrigerator, and I have stuff in there that I eat. Stuff that I want instead of stuff that other people give me and think I should be happy with. My health has improved the last couple of months. I put on weight because I've been eating healthier and eating better and eating more often. I'm better all the way around. I'm in seventh heaven. It's like a new beginning, a new start. It's like I can't wait to see where my place is in life.
think one of the reasons why I really like this, this video is to tell the story from people's perspective, and from Marvelin's perspective, this is so important for her family, for her, the way she connects with family, connects with her community, and we truly believe that no one in this country should go to bed hungry, just period. It's just not okay. The other thing I want to point out before I switch to talk a little bit about housing, the first cohort of the people we're engaging in California, you'd think that we're working with the Medicaid members or dual eligible members or Medicare and Medicaid. We're actually starting with our privately insured members. Those are members who are getting their coverage through their employers, and we've already seen 30,000 people in the process of applying and qualifying for food stamp. So it's just important to think about that for a moment. These are employed folks who are getting their coverage through their employer, yet they're still qualifying for food stamps. Let me shift gear just a little bit and talk about housing, which is another really important issue that I'm sure if you live in big cities, or actually also now even in suburban and rural America, you're facing a lot of the issues around housing and the homelessness crisis. The good news is that the overwhelming majority of Americans believe that you can't expect someone to live a healthy life if you don't have a stable roof over your head, which is a basic human rights. And when you look at the housing and homelessness situation in this country, every night there's over 500,000 people in this country who are homeless. Over 200,000 of those are literally on the streets. And when you look at California, a quarter of the nation's homelessness population live actually in California. And when you look at our footprint, when I look at, San Francisco, LA, San Diego, Seattle, Portland, Atlanta, other places are struggling with serious issues around housing and around housing. And we know that when you're on the streets, your cost of care is just higher. And I can show you, I'm a family physician. I spent most of my clinical care in health. I trained in a healthcare for the homeless program. I ran healthcare for the homeless program. And there's tons of evidence that shows you the direct connection between housing and health. We know, for example, that if you're homeless and you get admitted, you tend to stay 2 to 3 days longer in the hospital. If you're homeless and you're getting ready to be discharged, your chances of being readmitted are 50% higher. Your mortality rate is about 3 to 4 times that of those who are housed. Total cost of care is also 3 to 4 times higher than those who are housed. And we know that if you're homeless, your life expectancy is 27 years less than if you're housed. So think about that for a moment. So we've been spending a lot of time thinking about what is our role as an organization, not just with our own members, but really in the communities where we operate, to make sure that we're lifting up the preservation and the availability of affordable housing in our communities as a key health driver for those communities. So we've announced now a year and a half ago or so, $200 million out of our Treasury Department. And we took that money out of investing it in the market for a regular return, and we said we're going to dedicate those $200 million to invest in projects that would preserve or expand affordable housing in the communities where Kaiser Permanente operates. This was a big deal for our board of directors, for our organizations, for our CFO, for our treasurer, but we're really excited that we've realized that we can take those $200 million. We might not get the same rate of return that we get in the private market, but we're still going to get some return that would allow us to have not just a financial return on investment, but really have a social return on investment. And just in 1 year, we formally launched this program in January of 2019. And since we've launched it till today, we've closed on deals in Southern California, Northern California, in Baltimore, Washington, D.C., Denver, a couple of other places, and I think there are a couple here in Atlanta that we're in discussion about closing those deals. And this is basically where you tap into those resources and you give the project that's ready to go to the finish line the last stretch that it needs to close on the financing and close on that deal. and get to preserve or expand affordable housing. In the next few weeks, we're going to give a summary of the first year of this effort, and we're really, really pleased at how fast and how much demand there is in the communities where we operate to preserve and expand affordable housing. So we're really excited about that. But then we said, okay, our headquarters is in Oakland, California, right across the bay from San Francisco, and the number of people living on the streets in Oakland's been going up and up and up and up. And we said, is there something that we can do in Oakland, in our backyard, particularly focusing on those who are older, who have multiple chronic problems, or out on the streets, who we know they have significant issues with health and healthcare, and their total cost of care is high. So what can we do to address their needs? So we have a team from across the system that came and spent time with the community partners, with the city, with the county, and we were able to identify by name 515 people who are on the streets in Oakland, who are 50 plus, who have at least one chronic medical problem. And we challenged ourselves and we challenged the community. Can we get all those 515 people, get them off the street, get them housed? Everybody was like, I don't think you can do that. There's no way we're going to be able to do that. It's hard. There are all these challenges in getting housing. There's not enough housing supply. There are all these problems. These patients, some of them are dealing with mental illness, with substance abuse. It's impossible to get all these folks off the street. And we challenged ourselves and we challenged our partners to say, what would it take to get these folks off waiting list, get them into housing? So we've created a pool of resources, flexible fund, that we've made available to one key partner in the community. And we said, for those folks who we know by name, for these 515 people, everything you need to get them off the street, if they need a deposit, because I don't know how many people who are living on the street can have first month and last month deposit to be able to be housed. If they need support with legal to help them clarify some things in their background to get them into housing, let's do that. So we've identified a whole list of things that these organizations can tap into that fund for. No questions asked, just get these folks off the street. And we got 515 people off the street in 7 months. And that's, I think, the type of thinking that I would encourage, and I'm hoping more health system will start thinking about what would it take to get people off the street that are impacting, that have significant impact on the health of the communities. We've also tracked costs on how much it's costing us to get people off the street, and we have a full evaluation that will be coming out very soon about this effort. We've realized that out of the 515 people that we got off the street, there's about 20% of those who actually ends up back out on the street, even though we're providing tons of wraparound services around these individuals as they're housed. But it was really important that we, for this particular, those 20%, and they're usually people with mental illness and substance abuse, both, they're really difficult to house. And so for many of them, we had to house them twice or 3 times. And with all the wraparound services, it's still hard to keep them housed. But I'm really happy to report, like 6 months later, the housing stability rate, like 93% of these folks are still housed 6 months later. So we are really excited about that type of approach that's data-driven to help address this issue. And then we've realized that we need to think about how do we take this type of model at the scale. So we've partnered with an organization called Community Solution. They have a program called Built for Zero, which is a data-driven program that literally tracks people who are out on the street. And the same way we created a by-name list for Oakland, that's what Built for Zero does in every community that they're in. They're in about 70 communities across the country, and now we're partnering with them in 23 of Kaiser Permanente communities to get these communities to end chronic and or veteran homelessness. And we have 2 communities where really, really soon we'll be able to end chronic and or veteran homelessness in those communities. We're working with 23 communities there. So I'm going to pause here for a moment just to kind of re-emphasize why these issues are so relevant. The housing work, the food work. There's a whole body of work that that we are working on, that we need to continue to develop on social connectedness, and we know how important that is to health. Transportation is another health-related social need, and it's also important to spend some time thinking about the ability to pay your water bill, your electric bill, simple things, and yet we need to figure out how to address that. I had a series of slides to talk a little bit about our work in schools. So we're in about 1,000 schools right now working on healthy eating, active living. We just launched a new program addressing mental health and wellness in schools. It's really about building resiliency in schools, so I'm not going to cover all of that, but happy during the Q&A if folks have any questions on that. And then one last program I'll highlight is our work with City Health. We're working with the 40 largest cities in the country to adopt a set of policies that we know if those policies are adopted in those cities, community health will be improved. And we're working with the 40 largest in the country. This past year alone, when you look at these 9 policies, we've seen 35 policies getting adopted that impact the lives of 22 million people, things like Clean Indoor Air Act, and we're really, really proud of, I know we're in Atlanta, so we're particularly proud of Atlanta for passing a Clean Indoor Air Act this past year. And our Kaiser Permanente team, I know I've seen a couple of our KP Georgia members here, so we've done really good. We're really excited about the progress in Atlanta. But you look at all the progress in all 22 in 22 cities and the 35 policies that get adopted that would really help us lift up the conditions for health in the communities where we operate. So I'm going to stop here so I can allow some time for questions and answers, and then we'll have a few minutes for Q&A. Are folks expected to come here? Oh, somebody will be running with the mic. All right. Like 2 questions, one here and one there.
Hi, good afternoon. I was wondering for the housing program that in the housing in our backyard, did you also, you mentioned that folks had achieved stable housing. Mm-hmm. Have you measured health outcomes against that to see like how their health outcomes improved, along with their housing to be able to document and demonstrate that?
So the first phase of the evaluation has really been focused as, are we getting people into stable housing? Are they still housed? And what we've learned is 6 months down the line, 93% of folks have stable housing. We have a long arm evaluation that's led by Dr. Margot Cushel, who's a lead researcher on homeless and health. That's going to be tracking those folks for, I think, 3 or 5 years, and we're going to be learning along the line what happens to the total cost of care. Yes?
Hold on just a second. I think we have a question.
Somebody's there. Oops. All right. Okay. Who has the mic? Sorry.
So it's very inspiring. Thank you for sharing this with us. I had a question on the fund that you created to help those 515 people get off the streets. Approximately how much was that per person? That's one question. Second question is about the housing that Kaiser is investing in. Are you branding that as Kaiser, or is it privately branded?
Yeah, so thank you for raising that question. So when we did our first round of projections, we thought that we'll probably might need about $15 million for that flex pool for those 515 people. Once we get everybody housed, we actually only needed $7.1 million. So we are really actually happy that it's costing us less to get these folks off the street. And the main reason is we've realized that actually 68% or 67% of these folks have some type of income that they will subsidize their actual housing. What they really needed is just all the things around them to get them into housing, and then they can pay the rent if you find them the right level of housing. We've focused a lot on shared housing as a model. A lot of folks like you have your own apartment, your own, one-bedroom apartment or studio in the Bay Area, particularly around, in Oakland, where the overwhelming majority of people ended up being housed. That's really expensive. And if you're living on SSI, you won't be able to afford that. So we've done a lot of shared housing models where you actually have your own room, your own door, your own lock, but then you're sharing the space with others. And that model actually turned out to be a lot better for many of those folks who are dealing with not just homelessness, but also social isolation. As far as the housing, the 20 projects or so that we've closed on, we're not branding them as Kaiser Permanente. We've partnered with Community Development Finance Institution, the CDFIs. I know I saw Dr. Ross here, Sam Ross from Bon Secours. They're doing also fantastic work on housing. So we use the same model. So we've partnered with a third party that actually administer the funds. We have 2 funds right now. And then that third party works with not-for-profit developers who go and try to find buildings that are on the verge of losing affordability and be swapped to become market rate. They grab them, rehab them, and maintain them as affordable because we're offering those either the equity fund or the loans at a much reduced rate. But they get branded by the not-for-profit, usually developer who does this work. Yes?
We'll take one more question
One more
after
question.
that one.
All right.
Okay. Hi, my name is Alvin Lin, and I'm with SBH Health in New York. And we also did something similar where we donated land to a developer for 300 or so units. I'm wondering, how did you identify which of your members are eligible, and how do you track success over the program and over what time period?
So the 515 members, the folks who are on the street, some of them were our members, others were not. I mean, in Oakland, we have a really big penetration market share, so we know a good number of them were our members, but really that effort was a community-led effort, so it was not for our own members. The evaluation, though, that we're doing with Dr. Marco Cushel will be tracking the total cost of care for our members and those who are not our members. We are developing right now a much more comprehensive approach that's a systematic approach to making sure that our members who are at the risk of getting homeless, they're getting connected to the services that they need before they actually get homeless. And I think this is an important topic, and I don't know if those sessions today and tomorrow cover that. But the same way we're predicting who are the members who are likely going to have a heart attack so we can work with them earlier to try to prevent them from having heart attack, we need to get to a point where we can look at our 12.3 million members and just say, who are the 5,000 members who are likely going to end up on the street in the next 6 months? And then let's activate to support them and provide the wraparound for them so they don't end up on the street. So that kind of predictive modeling around social health is a discipline that we're building, and Dr. Anand Shah on my team leads that effort for the system. Right. One last question.
Last question, yes.
All right.
It's a very excellent work you can. Yeah, it's very excellent work. But I was curious, what are your funding sources to do all this great work?
Yeah. So, well, first of all, we are a not-for-profit organization, so we dedicate a pool of our resources to support community health as part of who we are as an organization. So last year we invested about $2.8 billion overall in our community health portfolio. A big chunk of that is provide medical financial assistance for our members and non-members. We provide Medicaid services that we lose dollars on, and we provide about $100 to $120 million in grants every year to community partners to help us deliver on that. So a big chunk of that really comes from our community health resources that we dedicate to that. And for our work to building the network of social providers, the same way we have network for physical health and mental health, this is part of our operation. I mean, we're bringing this work to the core of who we are as a business. And if we do believe that social health, physical health, and mental health, they all are equally important to the health and well-being of our members, we dedicate operations dollars to support this work. All right? Well, thank you.
Let's give a big hand for Dr. Choucair, actually, for your time. Appreciate it.